Hello, everybody. Welcome. If you are signed on looking for Hospice Corporation's webinar on dehydration in long-term care residents, you are in the right place. My name is Betsy King, and I will be your host this afternoon for the webinar. And we're going to get started in just about 3 or 4 minutes at the top of the hour. So if you have a second, click on the chat function and let us know where you're joining us from today. And we'll get started right at the top of the hour. Brad, I know where you're joining us from.
No, I was thinking of putting mine in there.
Get them started. Oh, there we go.
New Hampshire.
New Hampshire. Awesome. Welcome, Gail. California. Oh, well, California. Well, that's certainly both sides of the country covered.
That's right.
I know we have another team member in Florida that's joining us as well. Going to give it just another minute or two to allow people to get signed on, and then we'll get started. Hi, Shelley from Florida. For those of you just now signing on, click on the chat function and let us know where you're joining us from. And that's also where you can put any questions that you might have as we go along. At the end of the training, Brad is going to open it up to Q&A, and we'll be happy to answer any questions at that point. So looks like we're right at the top of the hour. So I would like to welcome everyone who's joining us today for the webinar. My name is Betsy King. I'm the lead clinical educator with Hospice Corporation and the Macy Catheter, and it's my pleasure to welcome you today. And it's also my pleasure to present Bradford Macy. Brad is the president of Hospice Corporation and a 30-year veteran hospice nurse. As a hospice nurse, Brad cared for hospice patients mostly in the after-hours setting, where he saw thousands of different symptom management cases. Out of a need for better management symptoms with oral meds at the bedside, Mr. Macy invented the Macy catheter. Brad was awarded the 2013 National Award for Hospice and Palliative Care Nurse of the Year through the National Board of Certification of Hospice and Palliative Care Nurses for his contributions to the field. Brad has presented and educated on issues related to end of life, serious illness, symptom management throughout the country and internationally over the last decade, and has contributed to research, including publications in the Journal of Pain and Symptom Management, in the Journal of Hospice and Palliative Care Nursing, and the Journal of Emergency Medicine. Today, he's going to be sharing his thoughts with us on hydrating patients and the issue and the problem of dealing with dehydration for patients who are long-term care residents. So with that, I am going to turn it over to you, Brad, and welcome you again.
Thank you, Betsy, and hi, everyone. Welcome, and thank you for your time. I know you're all very busy. It's been a challenging couple of years, and I thank you for your service out there to the elderly. It's been a tough couple of years. So dehydration is a serious issue in long-term care and among the elderly. And just, I'm going to review the incidence and morbidity risk factors, how to develop an action plan, and assessment monitoring, developing a risk assessment tool. And we're going to go over all of these things as we go through this presentation. But let's talk first about the incidence of dehydration in long-term care. One study found at least 50% of long-term residents are chronically dehydrated. They looked at 622 patients or residents and found an average daily fluid intake among those folks at 1,100 plus or minus 374 mLs in 24 hours. And it takes about 1,700 mLs in 24 hours or more to keep somebody hydrated. So you can see that the average fluid intake in long-term care, at least in this study, is quite a bit underneath that. A 2012 study recognized preventable admissions, 375,000 hospital admissions for dehydration, and 550,000 preventable emergency department visits for dehydration. So it's a serious problem. If we look at the comorbidities associated with dehydration, I know you're going to recognize a lot of these as reasons for hospitalization, including urinary tract infections, confusion, medication toxicity, pneumonia, pressure ulcers, hypotension, constipation, depression, falls, gastroenteritis, renal failure, and premature death and avoidable hospitalization. So it really, if we could come up with an action plan for dealing with and better hydrating residents, we can definitely decrease hospitalizations and certainly increase the quality of life for residents and probably decrease the burden on the facility related to these comorbidities. So that's kind of the goal of the presentation, to frame it in that perspective. I want to do a poll, and I'm going to ask several questions just to get folks to participate in this. And I want everybody to understand this is completely anonymous, so we cannot track your answers. We have no idea who's giving the answers. So I want to make that clear up front. But the first poll question is, considering these comorbidities that I talked about, and thinking about the admissions that you've had to hospitals or emergency visits over the last year, what percentage of those admissions or ED visits do you think were related to these issues? And Betsy, if you can pop the poll up now, and if people can answer, it'll be interesting to see what folks have found. So there it is. If you can just answer it, click on the answer, and then Betsy will present the results in a minute. So Betsy, let us know you're getting to tally on how many people have filled out, right? Correct?
I sure am. We've got 7 out of 19 people responding so far.
Okay.
So thank you all.
So we'll give it another 10 seconds. And
okay.
You can present the results.
Okay. Oh, it looks like it's pretty well split between all those options you gave them, Brad.
Really? Okay. Interesting. Very interesting. And one facility is one facility, right? There's a a huge range I found among what facilities are dealing with, what populations they have, um, whether they're long-term care or acute care, those types of things. So go ahead, Betsy.
Absolutely.
Let's take a look at the results.
Sure will. Here we go.
Yeah, quite a split.
Mm-hmm.
Very interesting.
Yeah.
But looks like more than half of the facilities are finding that 50% or more are related to these. Okay, great. So in order to, you guys have to click, oh, good, it disappeared on mine. So if the little boxes disappeared, great. If not, you just need to click close on your screen.
I closed it.
Let's talk about risk factors for dehydration. So among the general aging and care-related risk factors, obviously, as patients age, there's a greater loss of fluid through the skin. The skin is thinner. There's a loss of oils in the skin that keep fluid in. And so there's a greater loss. Decreased thirst perception is another problem among the elderly, so they may not be aware. Immobility is a big one. Either they can't get themselves to a source of fluid always, or they're concerned about getting to the bathroom. So they decrease the amount of fluid intake related to that. Enteral nutrition is another risk factor, primarily because of the osmolality a lot of times of the enteral nutrition. It tends to be hypertonic or isotonic. So we get a lot of fluid volume deficit or free water deficit. It's very hard to get free water in between those feedings. Medications such as diuretics, sedating medications, obviously diuretics, and sedating medications just because people may become less aware of what their bodily needs if they're sedated. Fluid restrictions is an obvious one. Thickened liquids, because the total amount of water within a cup of water of a thickened liquid is less, it can really affect how much water, how much free water somebody is getting. Restraints is another obvious one if they can't reach for water. Communication problems, environmental factors, heat, or very low or very high humidity. High humidity because it increases sweating, low humidity because it increases evaporation through the skin. Decreased symptom or disease or symptom-related risk factors are obviously dementia or cognitive impairment, depression, fever or infection, vomiting, diarrhea, dysphagia, and just multiple chronic illnesses are all increased risk factors for dehydration. So there are certain specific challenges that everybody has been dealing with in the last few years that have been extremely challenging for many skilled nursing and long-term care facilities that I want to talk about in particular. The first is emergent situations. So we're having, it seems like no matter where we live, we've got our own little issues, right? Out here in the West, we have fires. Midwest, tornadoes and serious snowstorms. South gets hurricanes. And the Northeast is getting massive flooding sometimes and severe weather. So we all get it. And some of the risk factors for dehydration during these things and pandemics can be excessive heat or humidity related to the storm and related to power outages and not being able to condition the air. Emergency medical system delays. So if we have patients that are lethargic or not hydrated well, can we hydrate those patients without the need for the emergency medical system? And it's something to think about in disaster preparedness planning. If there's a lack of hydration supplies or a lack of skilled staff to place, IVs or whatnot to hydrate, that's a challenge. And then, of course, the loss of running water is also a challenge sometimes. So actions that can be taken is to assure enough water on hand for 1 gallon per day per person for 96 hours. That's recommended in the CMS 2021 update. And I have the website file link here below. And then in my research, I found inline water tanks, and you all may have something like that, but I would recommend it. It allows you to store water in line so that you don't have to store water separately in containers and cycle through them, empty them. It just stores the water in line. And then stocking parenteral supplies for alternative non-parenteral means, or an alternative non-parenteral means of artificial hydration. And I'm going to talk about proctoclysis in this and how to hydrate people without the use of needles or parenteral supplies as an alternative. For this next poll question, how much emergency water do you store at your facility? Betsy, if you could pop that question up. And let's see what folks have to say.
So far, it's looking like greater than half a gallon a day for the majority of respondents. Got about 6 people answering so far.
Okay, let's give them 10 more seconds. And we'll
Okay.
move on. All righty.
Okay, we've got 7 folks responding, and here are the results of their responses.
Good, interesting. So more than 50% have a gallon per day per person, and that's fantastic. The other thing that the CMS guidelines were saying is, including your staff, making sure you include the staff, and even including some of the community that may be sheltering in place at your facility, like you've got enough to worry about. But it is interesting, and I'm glad to see that folks are doing that. Onward. So dehydration and COVID-19. This was a recent study just published a few weeks ago. They published on an emergency publication on it. They looked at several hundred residents, and they found that 60% of residents with COVID-19 were clinically dehydrated. So not a large majority, but a majority of COVID-19. Almost 20% had elevated sodium levels, and this is a loss of free water. So this is what's known as hypertonic dehydration. And so saline does not solve this problem, right? Because you're putting what they need is more free water. And they found that a free water deficit of almost 3 liters per patient was noted on average. Dehydration was significantly associated with falls and death. And so this was comparing hydrated versus dehydrated COVID patients. And they found more than 1.5 times the risk for fall, and almost 2.5 times the risk of death in COVID patients that were dehydrated versus COVID patients that were not. Reasons for dehydration obviously were persistent fever and a decreased ability to maintain oral hydration, even with assistance, due to decline in alertness and strength. And the other thing that wasn't mentioned in the study is just, in general, COVID patients have a harder time. There's less of a desire to take any kind of food or fluid intake in general with COVID. So it's just more of a challenge in general. So some of the actions they recommended were to be prepared to provide artificial hydration in about 50% of COVID-19 residents and to identify interventions that would be consistent with the goals of care that may lead to better outcomes for these patients. Dehydration in chronic and acute UTI, I included this also because this is an ongoing issue. It's the most common cause for hospitalization from bacterial infection. And just there's actually, even though this is such a challenge, there's actually been few studies done on dehydration and UTI. 2019 was somebody looked at trying to increase an intervention to increase hydration. And what they did is they set up 7 structured drink rounds. So people would push a cart around 7 times a day and offer fluids in between meals. And they were able to decrease UTIs and by about 58%, and they decreased hospital admissions related to UTI by 38%. So when we think about it, this was a small study. So the significance level was low on it, but it makes sense from a common sense perspective, because we think about the defense mechanism of the urine and colonization of bacteria in the urethra, moving up to the bladder and then moving up to the kidneys through the ureters. And then eventually, we go from bladder infection to kidney infection to sepsis. We can decrease that significantly with hydration because the high pH of the urine and the osmolality, the urine actually produces inhibitors of bacterial adherence. So the bacteria can't stick to the wall and to the urethral walls as well with more urine. And then just the mechanical flushing of urine down and out of the body decreases the risk of infection. So we've reviewed the morbidities and the frequency of dehydration and some of the challenges that are happening. What can we do? What kind of a dehydration action plan can facilities come up with to try to improve outcomes associated with that? And it all starts obviously with prevention. And then we want to screen patients early on at admission and continuously with MBS assessments. We want to continually screen to identify patients that are particularly high risk. And then we want to monitor those patients closely so that we can figure out when they are dehydrated. And that's through the identification process. So in the identification process, we want to define dehydration so that we set a bar. So if we know exactly a solid definition of what dehydration is in the facility, then we can identify those patients and treat them. But if we don't identify and have a definition of dehydration within the facility, we're never going to be able to identify them and treat them. So it starts again with prevention. And prevention starts with education, right? So if we can change culture, it's about changing the culture in a facility, educating the entire staff from housekeeping to families to nursing. Everybody is involved in education, making dehydration a primary front and center, and educating them in the risks, the signs, and the prevention of dehydration. It's a team approach, right, to monitoring for all residents. And everybody can encourage residents to drink. They go by, oh, would you like a little more fluid? Signs in the hallways to encourage and remind, because what teaching somebody once doesn't always mean you change their behavior. Changing behavior takes ongoing teaching. So I'm going to show you a couple examples of signs that I found online, which I liked, which can encourage and actually stimulate a person's appetite for fluid. So then, access to oral fluids is also super important, and a water-rich diet. And this is dietary, and I know most dietary programs include water-rich diets, but everybody can increase access to oral fluids. Identifying patients with what are a patient's fluid preferences. And why is that important? Obviously, if a person doesn't like something or they don't like water, I know sometimes with elderly and with hospice patients, I found people didn't like water. It didn't wet their palate, especially if they have a dry mouth. Water doesn't stimulate the desire to drink. So sometimes flavored waters, and this is where maybe the family can come into play and maybe bring some lemon in, maybe just a little bit of lemon in the water. Just thoughtful ways that people can increase fluids. And then providing scheduled drink rounds, just like the studies showed, between meals. I know this is a challenge with staffing shortages, but any way that we can increase access to fluids in the hallways, although that can be challenging too with COVID now, but once COVID is over, getting fluids in the hallways, things like that. And then providing fluids during activities is a big one. So anytime there's an activity, fluids, it's a social thing, right, too. So people will drink more in a social situation. Resident and family specific teaching. So it's best done during admission and the hydration risk screening, which I'm going to go over in a minute. I'm going to talk about the risk screening tool, which is done at admission. But when we're talking to families and patients, we can explain to them how prevalent dehydration is, that it causes lethargy, the inability, and we can really talk to that as an important factor in their care. Creating a handout for families is nice. And then teaching how much fluid is needed a day, so they understand, you need at least 7 cups a day, but it's even better if you can get even more fluid in your body. Describe and perform the screening and risk assessment tool and what they're looking at, and then talk about, and if we find that the patient's at high risk after the screening, we want to talk about some of the challenges of getting enough fluid in and the potential need for artificial hydration. Explaining to them what artificial hydration is, and then talking to them about whether that's something that they would be interesting for them as part of their plan of care, and getting the consent or refusal is important, because that will help us understand that patient's goals of care better. And if in fact they refuse it, they may be appropriate for hospice or palliative care, and the physician should be notified that the family is not wanting artificial hydration. And that's another conversation going forward that helps with that referral, getting those people in the right referral stream. So these are some of the poster examples. And I like this one particularly because, again, it kind of shows foods in it. People who may not be as aware that they're dehydrated might see this, and it might stimulate their appetite to take fluids. This one's also good, showing kind of symptoms of dehydration. This might be nice just as a handout or a fold out for families to take a look at, so that they can recognize when fluids are necessary. And here's these are some of the sites that I got these on. So here's our next poll question. How many times in 24 hours are fluids actively encouraged and offered between meal times at your facility? Betsy? I noticed we have a volume issue. Is that better now? Thank you,
Yes.
Julie.
Yes.
Fantastic. Thank you, Julie. Okay, Betsy, what do we
Ready
got?
to share? Yep. Here we go.
Yeah, 7 times is a lot. That's amazing that some folks are doing that.
Yeah.
It'd be interesting. But I always am interested in research studies. It'd be interesting to see what those, how that works for facilities, how you're doing with dehydration. Thank you, everyone. So the next step in the process is screening, right? And we talked about the dehydration risk assessment tool. We would do it on admission, and these are just recommendations that I have, and you would obviously come up with your own program. But on admission is super important, and then during the assessment, the MDS assessments, and as needed. But you would identify low-risk patients and high-risk patients. Low-risk patients, we want to continue to document and assess, obviously, but high-risk patients, we really want to start to monitor. And we would monitor intake and output. Output's sometimes hard with incontinent patients, so at least intake. And then blood pressure, pulse, and mental status every shift. And then, of course, as I said before, during the admission, we would talk to them about artificial hydration and find out what their goal of care is if they're high risk for dehydration. So this assessment tool, I got this from a study done in the United Kingdom on a risk assessment tool that they came up with. And I simplified it because I know how difficult programs are to implement in a busy day, in a busy facility. And I simplified it to make it a little easier to analyze and to initiate and complete. There's 2 parts to it. The first part is screening for the need and appropriateness of risk, of assessing risk. And the first, it asks, has the patient or family opted out of artificial hydration in their advance directive? That tells us a lot, right? That says, this patient is thinking about end of life. They don't want artificial means of things, and it's a very important piece of information. So we want to consider referral to palliative care or hospice for those patients. Second is the patient a hospice and palliative care patient already? And if they are, the hospice and palliative care team can be extremely helpful in talking about those decisions around hydration and educating and all of that. So you have help in that situation from other members of the interdisciplinary team. Is the patient potentially approaching end of life? Again, a whole different conversation about hydration emerges when patients are at their end of life. And I'm going to talk a little bit about that later on in the presentation. So if they answered no, to all three of these, then we really need to understand their risk for hydration. Part two is this is super easy because there's no adding up numbers or coming up with a number. It's basically if they answer yes to any of these questions, they're high risk. So the questions are, does the resident have dementia or cognitive impairment? Are they exhibiting early or advanced signs of dehydration? Are they on enteral nutrition or thickened liquids? Are they on diuretics, sedating medications, antipsychotics, or antibiotics? Are they unable to locate, pick up, or drink fluids independently? Have they had diarrhea, nausea, or vomiting in the last 24 hours? Have they been febrile in the last 24 hours? Or do they have dysphagia? And so these are all going to be challenging for patients to get enough fluid. You may want to add questions also. So right now, I just want to do another couple questions for the group. Based on these questions on the risk assessment tool, what percentage of your residents do you think fall into a high risk category for dehydration? And here are the questions here. And then the second question is going to be, do you have a dehydration risk assessment tool in use, either handwritten or in your EMR? And it would be really amazing. I've done this presentation once before, and I was surprised to learn that the facilities didn't and don't have it in their EMR. An EMR assessment tool would be amazing because it could automatically tell an agency when a patient's high risk for dehydration. So with that, Betsy, can you pop up those questions? Thank you.
There you go.
How are we doing, Betsy?
We have 10 respondents out of 25.
Okay,
Yeah.
let's give them 10 more seconds.
Okay. Looks like everybody's scrolling down and answering the second question as well.
Oh, good. All right, what do we have?
All right, let's end the poll and see the results.
Very interesting. It's super interesting to me. Wow, as many as 75%. And it's, skewed. So about half say, less than 25%, but 11 to 25. So pretty high. I would say people feel like the incidence of high risk patients is pretty high in general. And then look at this 50-50 split. But some do. Some 50% of the agencies have a risk assessment tool. That is great. And if some of you can share with others or publish your risk assessment tool would be, I think it's super, super important to push this and let people know what you're doing. Thank you so much, everyone.
Absolutely.
So the next step is to monitor, right? We know who's high risk and who's low risk. We still want to, for the low risk patients, we still want to observe their intake. We still want that team approach and that prevention. And we still want to document assessment and dehydration signs. But for the high risk folks, we're going to go a step further. We're still going to do our documentation, our assessment, but we're also going to actively monitor intake, output, blood pressure, and pulse every shift. And the reason we're going to do that is in our treatment phase or in our identification phase, we're going to be able to identify based on these things who absolutely is dehydrated. So if we go, first of all, let's talk about assessing and monitoring. So what are the early signs of dehydration? Thirst and dry mouth, but as I said, thirst sometimes may not be there in elderly. Dry mouth is the #1 sign, actually, of early dehydration. Constipation is certainly a sign, but it's also prevalent in old age, so may not be as much of a sign. Poor skin turgor is another really good way of telling. It's pinching the skin on the forearm and seeing how it bounces back. Dark urine is also another pretty good one. Decreased urine output, now that is a truly measurable sign. So if somebody is continent, just putting a measuring device in the toilet to measure the output could be a good way of being able to tell whether somebody's dehydrated. Weakness, headache, dizziness, sleepy, ADL decline are also signs. Advanced signs are a change in mental status, decreased urinary output down to less than 50 an hour. That's getting pretty dehydrated, and at less than 30 an hour, the kidneys begin to fail. So you're looking at renal failure. Tachycardia greater than 100 beats per minute and low blood pressure, a systolic less than 90. Orthostatic hypertension difference sitting to standing of greater than 20 systolic is another good sign. Rapid weight loss of 3 to 5 pounds in less than a week is going to be fluid and not obviously body true mass. Confusion, disorientation, and coma are the much later signs. So identifying dehydration and defining it, right? An oral intake less than 1,700 mLs in 24 hours a day is a good place to start. And so if we can monitor oral intake in those patients, we can recognize output less than 50 mLs an hour is dehydration. And then the BUN's creatinine ratio is another really good way to monitor. This was used in the study on COVID patients. So this is a third measurable sign of dehydration. Last thing is treating. So now we have a definition for dehydration at our facility. What are we going to do about it, right? So if alert and oriented vital signs are within normal limits and the urinary output is greater than 50 an hour, we can push PO fluids, okay? So we really want to try to push PO fluids first. We obviously don't want to go to artificial hydration unless we have more advanced signs. But if a resident and family consents to artificial hydration, we would initiate artificial hydration if there's an altered level of consciousness, if the systolic blood pressure drops below 90, if the pulse goes over 100, the urinary output is less than 50 mLs an hour, or the temp is greater than 105. Now you have parameters, and obviously you can set parameters at your facility per your physician's nurse practitioner, whatever the prescribers come up with as parameters. Having parameters is super important, because if you don't have a bar for treatment. So also the other thing that you can do is consider a baseline BUN and creatinine level, if severe, so that you know what's going on with those patients. So if artificial hydration is decided upon, what are some of the clinical guidelines that we want to consider? Ethically, clinically, what are all of those thoughts around those types of things? So First of all, education of the patient and the surrogate and choices, benefits, risks, burdens, goals, and the predicted length of hydration are super important. Providing the least amount of fluid necessary in the shortest possible time to achieve the desired goal, which is obviously getting the patient out of the dehydration place so that they're drinking more than 7 cups a day. Their urinary output is returning to normal. Use of the least invasive and safest method possible. Constantly monitor for the effectiveness of the hydration and any adverse effects of the hydration. And then stop the artificial hydration when your goal is achieved. So when writing orders, the prescriber can say, hydrate until, urinary output is achieved, or until oral hydration meets X, Y, or Z. So let's talk a little bit about hospice and palliative care and any clinical indications for artificial hydration in hospice and palliative care. Primarily in hospice and palliative care, we do not hydrate, especially at the end of life, right? The patient is declining. They're approaching end of life. The body's need for water decreases and all. So, but if there are some instances where a patient in hospice and palliative care could also use or could need fluid, and that if the patient is not actively dying, then there may be instances where they have nausea, vomiting, a flu, or other infection. So these are acute situations, excessive heat or toxic metabolites. Acute situations where the patient's quality of life may benefit from artificial hydration, or where hydration may improve the physical quality of life could be delirium, a bladder infection with severe discomfort. I saw that quite frequently, to where patients would have constant discomfort from bladder infections, and antibiotics wouldn't work because we weren't flushing the bladder out enough. So there just wasn't enough flow through the bladder to decrease the discomfort. Toxic metabolites from drugs, I've mentioned that twice. Electrolyte imbalances is another potential. And then mechanical blockage, esophageal or throat cancer. Sometimes patients have end of life or life events in which they want to make. I had one gal one time want to go to Disneyland with her grandchildren. And she hydrated herself at Disneyland, came back. She had a terminal bowel obstruction. She hydrated herself at Disneyland and then came back and died a week later. So there are times or situations where hydration is appropriate with hospice and palliative care. Teaching points for families, teaching is so important, right? Because a lot of times families may not understand that patients' need for hydration decreases at the end of life. And these are some of the important points that you can share with family, that dehydration is not an uncomfortable process at the end of life, and it actually provides a natural anesthetic. Artificial hydration can limit mobility and cause discomfort. Dry mouths and lips can be managed with chapstick. Lethargy is not due to dehydration. Sometimes, families think, oh, my loved one's dying because they're dehydrated, and we need to kind of switch that around, and we need to point out that no, they're dehydrated actually because they're getting to a point where they're dying and they don't need that fluid anymore. So talking to families in that way can sometimes avert unnecessary artificial hydration. Discuss past experiences of love through feeding and new ways to express love. A lot of times families are like, well, we always fed each other. That was such an important part of our family, and just saying, maybe just holding your mom's hand, or telling her you love her. Maybe that's a better way to express your love at this point, because her body's shutting down and she doesn't need that food and she doesn't need that fluid that she used to need. And so just using those as ways to talk to patients sometimes really helps. Now we're going to get into methods of artificial hydration. And there's 3 methods that I'm going to discuss. I'm going to discuss IV, intravenous, subcutaneous, and proctoclysis with a rectal hydration and medication catheter. So the first one is intravenous, and we're going to look at the benefits, downsides, burdens, and risks. The benefits are versatile fluids, and it's the highest delivery rate. So if you've got someone who's severely dehydrated and critical, obviously this would be the way to go. If somebody's in shock, the downsides, usually outweigh the benefits in hospice and sometimes in skilled nursing. IV fluids are difficult. Sometimes IV sticks are difficult in patients, elderly patients that are dehydrated. Sometimes getting the nursing staff skill level, especially in emergent situations, can be challenging to get IVs started. And so it can be delayed if you have to bring in line teams to place them. It's the most painful and invasive way to provide fluids. And it's difficult to initiate and maintain sometimes. High caregiver and nursing burden, pharmacy delivery of supplies, highest cost option, needs RN or LVN certification, and the risks are fluid. The fluid overload risk is the highest potential for IV because you're dumping the fluid directly into the circulation. Needle injuries, infection, infiltration, and dislodgement are also risks associated with IV. Hypodermoclysis is the next one. This is subcutaneous delivery. You usually use a 22 to 25 gauge needle. It's a small needle. Need to find a site with adequate subcutaneous fat tissue. That can be challenging in elderly patient. We want to avoid irradiated areas. Avoid the thigh areas if there's lower extremity edema, because you're just going to increase, that fluid's not going to go into the circulation, right? It's just going to increase the edema in that extremity. Avoid the abdomen if there's ascites, because we don't want to puncture the abdominal wall. Common fluids are normal saline. So a comment about hypodermoclysis. Usually we use what we call isotonic fluids. And that's a challenge for when somebody has a free water deficit. For instance, we were talking about that in COVID, and in general, it's free water deficit. Dehydration in skilled nursing is free water deficit. So we want to use hypotonic fluids, fluids that have more water in them, more free water in them. And it's difficult to do with hypodermoclysis. And high sodium levels are not unprevalent in long-term care. So we want to watch out for exacerbating the problem of elevated sodium by continuing to provide sodium-rich fluids if somebody's dehydrated. Checking sites for redness, swelling, hardness, discomfort daily. An infusion rate of less than or equal to 80 mLs an hour is usually recommended. So it's a relatively slow way for hydration. Bag change is recommended every 24 hours and a tubing change every 72. Site rotation every 24 to 48 hours, or after about 1.5 liters to 2 liters of fluid at that site. Some of the benefits: it's easier than IV, and it's mostly pain-free. Those needles are small. Where pain may come into play is if there's swelling at the site from the water not absorbing. So that can be a challenge. Loss of home atmosphere, high caregiver burden, pharmacy delivery of supplies and pumps can be challenging. Some of the limits I talked about: isotonic fluids, and we can't administer meds via the same port. So sometimes we want to give medication you can't use the same needle with hypodermoclysis. You'll have to use another needle to administer medications. Very difficult with cachexia and fat wasting or with edematous patients. It's not helpful for hypertonic dehydration or hypernatremia or free water deficit. Risks are fluid overload, potentials lower than IV. Pump is recommended in the home setting. Needle-related injuries and complications, dislodgement, and subcutaneous fluid accumulation are the risks associated with them. So proctoclysis is the last one, and this is rectally delivered fluid. No needles are needed. It's comfortable and safe. The balloon blocks the fluid from pushing against the rectal sphincter. So what it does is it blocks that feeling of discomfort associated with fluid in the rectum. And then absorption actually occurs in the descending colon, which is, that's basically the function of the descending colon, is to reabsorb fluids. So you can give quite a bit of fluid. You can give up to 250 mLs an hour, but you need to space it apart. You can't run it continuously. You should give a spacing of at least 2 hours apart with a maximum recommended volume of about 2 liters a day. So it's not, it's not like IV. You can't give that same. That said, most residents, 2 liters a day is plenty, especially if they're able to drink in addition. Inpatient gravity bag is used. You can use a kangaroo bag to connect to this catheter, and I'll go into detail about the catheter in a minute here. The benefits of proctoclysis are its rapid and easy initiation. You can place the catheter very quickly, and you don't need high skill set. The IV certified nursing or things like that. It avoids the wait for deliveries and lines. It's less costly than parenteral, and it's safer. You can administer meds via the same port. Burdens, some stool or residual may be expelled after the procedure. So that can be a plus or a minus. If a patient is super constipated, it actually can help clean the patient out and get them feeling better. But you want to place an incontinence brief underneath the patient and ensure access to a bathroom commode or bedpan. Some of the downsides are limits to fluids. So it's more hypotonic, which is actually, so that's good for hypertonic dehydration or the loss of free water, but not as good for volume replacement. So if a patient has a low sodium level, they're going to need other means, probably IV means to provide the replacement of fluids. You can use Pedialyte, oral rehydration, or another type of oral rehydration solution. That's fine. Those are still hypotonic. They're not iso or hypertonic. And you can't use it with diarrhea. Fluid overload risk is lowest for proctoclysis. So there was a study on using a rectal administration catheter done. Bob Parker did a study in 4 nursing homes. It was a small study. They looked at comfort and whether they were able to decrease hospitalizations. You can see 9 of the 11 interventions, they were able to manage the incident in the facility. Patient comfort was reported in all 100% of the patients reported comfort. Staff reported comfort in 100% of the patients that were unable to report. And the prescribing clinician reported that the hydration was successful in 100% of the patients. So in review, we're running to the end of the hour. I think I'm going to skip the review and open it up to quick questions at this point. So anybody have a couple questions? I can also stay over if anybody wants to stay over, but let's open it up to questions. Thanks, everyone.
Thanks, Brad. Anyone attending can type their question either in the chat function or the Q&A box. And you can find those by scrolling down to the bottom of your screen and clicking on that icon. While we're waiting for people to share their questions, I will just remind anyone watching today that has a nursing license of any type can receive continuing education credit for attending this webinar. You will receive a course evaluation by email from us. Once you fill out that course evaluation and return it, we will return a CE certificate to you within about 5 business days. So be on the lookout for that course evaluation. You do have to complete that to receive the free CE credit from us. Don't see any.
I answered everybody's questions, Betsy.
I know. I don't see anything in the chat. Oh, here we go. Can you go over the hyper and hypotonic again?
Sure. So patients that aren't drinking fluids for longer periods of time usually tend to lose water, not salt and water. Patients, for instance, that have diarrhea or nausea and vomiting will lose both salt and water. And so we need to replace both in those types of patients. Whereas in patients that are chronically dehydrated tend to just be losing water. And that's when sodium levels go up. And we have what's called hypertonic dehydration. So in those patients, we want to replace replace free water, just water, not water and salt. In patients, for instance, blood loss, bodily fluid losses, usually we have to replace both water and electrolytes. And that's usually hypotonic. Sometimes it's hypotonic dehydration. And so we would want to use lactated ringers or, normal saline or something like that. Does that describe it better? But for most residents, it's plain good old dehydration, hypertonic dehydration. They need water. They don't need as much electrolytes.
Very interesting. Thank you, she says.
Okay.
Anything else?
I think that's it, Betsy, and we're at the top of the hour.
Perfect timing. Well, Brad and I want to thank you all again for joining us. And I also wanted to share with you, if you found this webinar helpful and you'd like to share it with your staff or other colleagues in the field, it will be available on our website in about a week or so. You'll be able to go to macycatheter.com, click on webinars, and you will be able to watch this on demand anytime. So you can share that, and we're happy to provide that service to the community. Anything else you want to say, Brad?
Well, yeah, we have a Relias Academy that has a lot of free CEs. So when you go on our website, you can go to the Relias Academy. We have a skilled nursing section and a hospice and palliative care section. We have one other free CE in skilled nursing that you can access if you'd like to watch that, and tons of hospice and palliative care CEs. So thank you, everyone.
Thank you. Have a great day.